regular conference in the future. All right, without further ado, let's do our real-world panel talking about how to implement all this cool stuff we've been talking about, not just for opioids, but for substances in general, in the real world. Chris Dunn, who is a PhD at Harborview, is going to start us off. I'll turn it over to you.
Thanks.
Thank you.
Hi, everybody. Well, lest you fear that you're going to be overtaken by late afternoon fatigue, I'll try to compensate with some humor, entertaining and statistically irresponsible opinionated statements for a change that might wake you up or at least stir the blood. I have a kind of a biased clinical / training perspective. I'm not a principal investigator. I've spent my career working for PIs, almost always teaching and monitoring the fidelity of motivational interviewing, brief interventions, and also working on MI, randomized training studies. So I'd like to talk a little bit about one thing that I think may be that may account for some of the null findings in the SBIRT efficacy research. So my bias is that the SBIRT glass is half full, but that there are some occasional empties that we've encountered, some occasional null studies. And I think part of the problem is misguided inclusion and exclusion criteria, which I don't want to talk about, but I do want to draw attention to the style of interacting during these brief interventions, because my bias is that the words that we use and our style of patter are pretty important, especially when you're an interventionist and you can't flush someone's line, you don't have authority over them, you don't have leverage. It's really a bare naked kind of a sport. You know, it's sort of like pole vaulting without the pole. And it's all you really have is your rapport with the person. And I think there may be some problems with a normal, what I've mislabeled here as a North American style of patter. That's probably a bad term for it. But a problem-solving medical or mental health, behaviorally oriented approach, a kind of a rational, persuasive model, I'm going to argue is culturally inept for dealing with an addicted population. I think that's a cultural clash. Now we've been taught to be careful about cultural groups defined ethnically or geographically, but what about a cultural group that's defined by a lifestyle of substance abuse, for example? Lifestyle is a huge part of culture. When you speak to someone in a certain way as if their lifestyle were a problem, it may be difficult to get an effect from that intervention. So an interrogative style, that's my own pejorative term for an ask and tell style. How long has the problem lasted? Or spending precious minutes on the RT part of SBIRT instead of the BI part of SBIRT, and the BI part is largely a motivational thing where you give them feedback and in the hopes that you'll make it more important that they change. There isn't time to do both RT and BI very well in 7 minutes. I think the 7-minute term is very reasonable. But I don't think you can do both. I think it's hard enough to do drugs. I think you either have to see yourself as a referral to treatment specialist, and if you're doing that, I hope you're doing it in a state where treatment is available. Because 50 years ago, in 1960, you can find studies where doctors were tearing their hair out trying to refer alcoholics to treatment. So if you have it, great. Hook them up. People do better in treatment. But there's a reason that 90% of the pyramid that Dr. Nofrio showed us aren't going to treatment. There are millions of addicts in this country who will never go to treatment, and they don't want anything to do with treatment. And you're not going to budge that with a brief intervention, but they might want to quit doing drugs. So if they want to quit drugs, and from a position of authority, you tell them that they need treatment to quit drugs, you're malpracticing because you're violating oodles of research showing that more people quit without treatment. So if you give them a message that they're not going to quit unless they do treatment, you better hope they go to treatment because you may be harming them if they don't go to treatment. So it's a tricky thing. I love that like Ed has success in getting people to go to treatment. That wouldn't work in Washington State. I tried it in a randomized trial. People go to treatment when the judge calls them in for drunk driving. And then it works really well. But what about the 90% that don't go? Well, it's possible. So I think you have to pick your battles in motivational interviewing. And giving unwanted advice is probably a cultural violation. Focusing on the how of change rather than the why with someone who hasn't resolved the why yet is possibly a cultural snafu. And so as a white male who's discovered 1,000 ways to stick his foot in his mouth with non-white cultural groups, I think this is another way to do it, is to not really understand where they're coming from. Now, I wasn't going to do all those editorials, but that's all you get now for editorials, except for this non-evidence-based equation here. SBIRT is to SBIRT as a horse is to carrot. I think that the antidote for a style of pattern that may be ineffective for some populations by some clinicians is motivational interviewing. And it is difficult to learn because it's asking people to change their own culture. I mean, how you talk to people is also part of your culture. And if motivational interviewing training asks you to speak differently to people, you're going to have to really strain to do that. So I'm going to talk about the training element of Doug's DOSBI program, which stands for Developing Organizational Screening and Brief Intervention, and try to describe what Doug and I think is probably a disseminatable dose of training, because teaching MI, not that that's the only way to do a brief intervention, but we've got to resolve the training issue for those efforts that want to use motivational interviewing, and training as usual is not going to be disseminatable. So I'd like to, the appeal of motivational interviewing, which is just to define it quickly, it's a style of talking to people in a way to mobilize their inner motivation, their internal motivation to change. And it's specifically designed to talk to people who are ambivalent about change. And if you talk to most drug addicts, they are very ambivalent about change, with the exception of, in some settings, marijuana, where people are not ambivalent about change. Most heroin, coke, meth addicts know that it's hurting them, and they will speak against the drug as if it's hurting them, and they'll also speak against change as if they don't want to change. So MI is custom made to counteract some of the problems with patter, and it's custom made to address ambivalent people. And as such, I think it's should be a little more widespread than some other specific styles of counseling. I think it's a style of interacting that maybe should be trained in a widespread way, but guess what? It's my whole career. So there are two processes of SBIRT, and it's been fascinating to hear the success stories here. Processes of care. One is to use people already employed in the emergency department who are what I would call home team players, and the other is to use designated hitters, specialists brought in. It may be easier to train specialists who don't have 20 years of social work with Harborview's safety net population, pointing these people in the right direction, saying, when you go out the door, don't go left, you'll die, go right. So that's a difficult thing to change. And so it may be that people who don't have a career yet and have been hired as health counselors, they may be more trainable. I'm not sure. It's just, but I worry that maybe this is a big moderator of some of our efficacy trials in SBIRT. It may be that using a team player, a home player versus a designated hitter, or the other way around was what screwed up the study? Not sure, but I hope that we can study that a little bit more, because I think that might be that's a decision that's usually made in the first week of the study, and it has a huge trajectory of consequences in both directions. So motivational interviewing has about 30 studies that have been published on an integrity measure or a fidelity measure. The quality of MI is measured, and it's really difficult and really expensive, but it at least has gone far beyond any other measures of psychotherapy fidelity that I've ever seen. It isn't just, did you ask someone the pros and cons of changing, which is a checklist, yes or no, occurred or didn't occur item, but it's also a how well did you do that, and that's where it gets expensive and difficult to measure. But the way motivational, but at least there is a way, however expensive, to rate the integrity or the fidelity of motivational interviewing. And we're working on, Dave Atkins is working on a way to teach a computer to do this using text mining, linguistic scientists, and acoustic linguistic scientists. I thought it was science fiction when I first started working with them, but I think that it may be possible to do that, and then if you had computerized scoring, then you'd have some quality control that was inexpensive, but it's down the road at this point. How is that motivational interviewing trained right now? Normally, the world, like when I say the world, I mean across countries and especially in North America, agencies call and ask for motivational interviewing training. They want a workshop. They do not want an obligation to ongoing coaching and supervision, because they don't, the people hiring you to give an MI training don't have the power to change how their agency is done. They can pay barely to have 20 counselors sit in a 2-day MI workshop and pay their salaries and pay the trainer. They cannot pay, nor do they have the power to change how the clinical workflow is such so that you'd have group supervision and you'd have a paid MI coder on staff listening to audio tapes. I mean, that is a pipe dream. To be able to really have the kind of supervision and training that we've done in randomized trials and motivational interviewing is never going to happen in the real world. So usually what they do is they go to a 2-day workshop, the counselors do. In fact, way more than half the counselors in the world have been to motivational interviewing workshops. It's a very popular brand name of counseling right now. Then they do no formal ongoing training, coaching, feedback, but they do catch-as-catch-can participation in further MI workshops. That's not an expensive, an inexpensive or a very effective method of teaching MI. So in Doug's study, he had 20 middle majority in terms of org readiness hospitals, randomized them to get or not get formal training. The control group was allowed to get workshops on the fly, participate however they could to learn motivational interviewing or brief intervention. And the intervention group had a little more formal training, and we tested a training package. How am I doing on time? If I got 10 more?
You got about 3 more minutes.
Oh, I'm on 15. Oh, this is bad. It's every bit as bad as I knew it would be. Thank you. Where were you 5 minutes ago? So, I'm sorry, you guys. This is the punchline. It was a 1-day workshop instead of a 2-day, which I don't think contributed much to the learning. I think you could probably swap a webinar for that. The 4 cycles of telephone standardized patient role plays is very inexpensive. The social worker in the trauma center gets a page, answers the phone, does a long-distance telephone role play. The trainer listens to the audio recording, emails feedback. The trainee is just basically doing all this while she's at work answering pages, getting people to and from nursing homes as a trauma social worker. It's very doable. And then some coaching phone calls that could be done from a training center or a centralized training telephone center. This is the study design. There were 7 SP scenarios measured and scored over 27 months, very long follow-up training. The line with the arrows designates when the end of training was, and the red SPs were dual-purpose SPs. They were practice SPs, like in the control group, where you get to practice your brief intervention on the phone, but they were also training SPs because they were accompanied by feedback. That feedback stopped at 6 months, and then for month 12, 18, and 27, we looked at skills. There were social workers and trauma nurses. They were almost all women who were in the training or the control groups. And here is the results of 1 of 12 MI fidelity variables, MI scores. The ratio of reflections to questions is an important variable because most people make about 1/3 of a reflection for every question they ask when they treat patients, when they do brief interventions. That means they ask 3 questions for every summary statement they make. They're not listening, they're asking, and that's what I call interrogation. It's more in that direction. And so at baseline, both groups made about 1/3 of a reflection for every question asked. And at 1 week, which was after the workshop, if they got the workshop, which meant that they were not in the control group, that number roughly doubled and pretty much held steady. And so I wasn't surprised that we did better in the intervention group up until the 6-month mark, but they never heard from the trainer again after 6 months. The training ended, and then at 7, 12, and 27 months, they held steady. And that is a hard habit to change. It's much easier to go back to asking closed questions and to telling patients what to do than it is to stay with that gain of motivational interviewing. However, 0.8 is slightly below the 1.0 threshold for basic proficiency in motivational interviewing. So what we had was roughly twice the R-to-Q ratio among the trained group, but they weren't quite sparkling yet in their motivational interviewing. They were not real strong counselors, but they maintained these changes to a large degree. Thanks, Megan. I can't read it, but that probably said sit down. How much did this training translate to changes in drinking? Doug showed you the big picture, and it may have looked like a null study to you. It looked like this. All patients had a very small difference, a very small advantage for those patients who received interventions by the trained people versus those patients who received interventions by the control group people. But when you break out and divide this is with traumatic brain injury, here's your parallel lines, and without traumatic brain injury, here are your bigger effects. So this, I think, is an example of where you might have said, oops, here's a null. This might be, I mean, depending upon what you consider a null, this might have been a null SBIRT intervention, but it had 50% of people with brain injury in it. And those 50% did not do that well with brain injury versus without. So that may be a selection issue and maybe a result, that may be a reason for why we have some half-empty glasses out there still. Thanks.